Welcome everyone this evening you're tuning in through Facebook, through the Star Hospice Facebook page. I want to welcome you. My name is Patrick Canty. I'm publisher of the Odessa American, and it's my privilege to host this conversation this evening. It's the second one we've had with a group of incredibly talented and dedicated physicians from the Midland and Odessa area. This is the second Facebook conversation that we've held that's hosted by Star Hospice. And we'd like to thank Mr. Ravi Shankar Murray for coming up with this series of conversations. Ravi's been an Odessa resident since 1997, and he started Star Hospice a number of years ago, and it serves an 11 county area of West Texas. And he thought it would be a good idea to have this series because basically day in and day out, I think we all have lots of questions concerning this virus. And we hear a lot of things from the kind of the public health standpoint, but nothing beats hearing from the doctors themselves that are there day in and day out providing healthcare to these people in this critical need of it. And so tonight what we're going to do is in our first series, we talk about kind of outpatient care, more general questions answered about, what are the symptoms? What can I do to keep from getting sick? What happens when I am sick? And at the tail end of that one, we kind of started talking about where we are tonight with this topic. And that is, okay, outpatient didn't work. I've gotten sicker and now I'm in the hospital and I'm in the intensive care unit. I'm really sick. And so tonight we're going to have a conversation with the physicians behind the mask, basically the doctors that work in the hospitals, in the ICU units, dealing with, all sorts of the specialty cares that people are required to undergo to try to recover from this disease. So I'm going to introduce them now, but before I do, if you're watching and you have questions, we'll be having some discussions about a various number of topics. But if you have a question, go ahead and message it in to the Star Hospice site, and we'll be given those. And as we get the chance, I will weave them into our conversation. So with that, I'd like to introduce our panelists tonight. First off, we have Dr. Gerardo Catalasan, who comes from the Philippines. He's been an Odessa, Midland resident for quite some time, but Dr. Catalasan is he's an assistant professor at Texas Tech Health Sciences Center, but more importantly, he's the medical director for the ICU unit at Midland Memorial Hospital. He specializes in critical care, neurocritical care, and pulmonary medicine with 24 years of experience. He finished his internal medicine residency at the Albert Einstein Medical Center in Philadelphia, and his pulmonary and critical care medicine training was from the University of Southern California in Los Angeles. Next, we have Dr. Alexander Bastidas, a native of Colombia. He's an internal medicine and critical care specialist, intensivist in Odessa. He graduated with honors in 2000. He has more than 20 years of diverse experiences, especially in critical care. Dr. Bastidas affiliates with Medical Center Hospital, and so we welcome him tonight here too. Next, we have Dr. Khavar. He's been in Odessa he's another local legend, so to speak. He's a pulmonary and critical care medicine specialist here in Odessa. He has over 25 years of experience in the medical field. He completed his advanced medical training in the United Kingdom. He's a member of the Royal College of Physicians there. And then he came over to the U.S., where he completed his internal medicine residency, training at the University of Connecticut School of Medicine, and then fellowship training in pulmonary and critical care medicine at Cornell University Medical School. He's director of the critical care unit at Odessa Regional Medical Center, and he also covers the ICU and COVID units at Medical Center Hospital in rotation with his intensivist colleagues. Next, we have Dr. Alejandra Garcia Fernandez. Dr. Garcia comes to us from Venezuela, and she's been here in Odessa. Let's see, she graduated with honors in 2011 from medical school. And so she has more than 9 years of diverse experiences, especially in critical care, internal medicine. And she's also, let's see, you affiliate with the Medical Center Hospital and Texas Tech Health Sciences Center. So we're so glad to have you here as well. And last but not least, returning from our last visit is Dr. Anand Reddy. Originally from Bangalore, Maine, Dr. Reddy is board certified in internal medicine and specializes as a board certified nephrologist, and is also trained in the United Kingdom, a member of the Royal College of Physicians. He's been practicing for over 9 years in 6 locations across West Texas. And he's also a clinical associate professor at the Texas Tech Health Sciences Center here in Odessa. He's director of the Permian Basin Kidney Center, and he's been recognized for the Service Excellence Award for core values and service by the DaVita Physicians Leadership Group. So welcome to you all. And I think we want to get this kicked off. And I think the first thing we want to do is, obviously, your professional lives have not been the same as they were 24 months ago. So what I would love for each of you to do, starting with you, Dr. Bastidas, is maybe go around the table and kind of describe what your day is like now amid, dealing with COVID.
Well, thank you for having me here, and thanks for this opportunity to share with the community what has been our experience dealing with patients during this pandemic. I can tell you it has been like a process from the beginning of the pandemic, and it has been like a adaptation process for us as well. I can tell you, like from the very beginning of the pandemic, we're talking about February, March. There was a lot of fear that you can see in the staff and the healthcare providers, the nursing. We're trying to learn how to protect ourselves, how to optimize our PPEs. You can see a lot of stress. I mean, now the stress is still there, but we kind of learn how to live with this day by day. I mean, it's definitely completely different to what we used to do in the past. I can tell my day when I'm in a COVID unit, it starts for me making sure I have all my appropriate PPE, my protection and everything. And then, start like running with the COVID patients. It's a different scenario for me. And the most difficult part for me has been kind of having a little bit like distance, when you have your PPE, when you have a mask, when you have everything, you lose a little bit of personal touch with the patient. Mm-hmm. And it has been very difficult, especially because we have very sick patients who are intubated, who are sedated, and they don't have the families there. And it has been the most difficult part for me is try to adapt to that part, like mm-hmm. Losing the communication with the families. It has been very difficult. So that makes our life harder, I think, in terms of the day-to-day. Mm-hmm. I really miss, like, even just like talking to families or having that personal touch that, sometimes, because we deal like, when patients are probably in the worst times of their lives, we know patients are in the ICU, they're critical. And so that has been very hard for us. So that probably has been for me the most dramatic change. Is just not having families there and losing the personal touch, and then us covered with layers of PPEs, and then just it's kind of surreal a little bit.
What about you, Dr. Garcia?
Different. I'm the newest in the specialty. I finished my fellowship in the middle of the pandemic.
Oh, what a great time to start.
Right. So I got a little bit of the initial experience where I did my training in Pennsylvania, and then came back to West Texas. So it's been hard. I echo what Alex was saying. It's been a constant adjustment. You start your day with a high census of patients, so you have many more patients that you would in a standard ICU on a normal daily basis. It's all the time it takes to put on your PPE, your protective equipment, to make sure you're doing things the right way for yourself, for your loved ones, and for your patients. Rounds take longer because of the same issue. There's a lot of logistics into putting everything you have to put on before you go in a room, and then remove stuff once you're out of that room before you go to the next one, plus all the cleaning, etc. Unfortunately, we're losing patients. We're losing much more patients than we have been on a standard ICU, which takes a toll on you as a person as well. The difficulty of caring for patients, not having their loved ones, the distance of the loved ones because they're not able to be physically there. The anxiety for the patients. We are seeing more younger patients, prior healthy patients in our units, which is not the standard patient that comes to the ICU. Younger scare patients that are able to communicate, and they're talking to you 1 minute and then a couple of hours later they're in an induced coma because of how sick they get. And then after your date's over and you try to do your best for the patients you're caring for, you still have to go home, and all the logistics of coming home have changed as well. So you use the specific clothing that you remove before you enter your house. You go straight before saying hello to anyone to go take a shower and make sure that you're trying to keep your families safe as well. And that's for the ones that now have the availability. But at the beginning of the pandemic, a lot of us were not even going home because we were so afraid that we were going to put our loved ones at risk that, we were keeping the largest amount of distance that we could in order to protect them. So it's definitely an adjustment.
Wow. What about you, Dr. Reddy? What's your day been like day in and day out since this virus started?
So mine is a little different, Pat. I'm more of a sidekick to these guys, so to say. I provide renal replacement therapy, which is basically a life support for the kidneys, which is similar to the ventilator, but it's a dialysis for the kidneys. And as the others said, we are seeing more and more patients. I see 4 different kinds of patients in my practice every day. The patients with pre-existing kidney disease already on dialysis who develop a COVID. We have strict outpatient regulations that we have to do similar to what they're doing in ICU to see the patients in the dialysis unit. They're maintaining the staff not getting the COVID, maintaining the patients not getting the COVID. It's every time the patient changes from one patient to the other patient, the cleaning, the whole process takes a longer time. We have a strict regulations where one patient comes, then the other patient has to be put on the chair in 15-20 minutes. That's how we used to run. Now we can't do the same. So we have a more lag period in between, and some of their patients' times have been changed. That adds to the difficulty of adjusting the time hours. And we have patients who develop kidney issues with COVID. Those are the sickest of the sick. Unfortunately, what we call the multi-organ failure patients, those who are already on life support for the lungs, now they develop the kidneys, which is not working. So for the lungs, the ICU intensivists, they provide the life support with the ventilator. Now comes the kidneys, which is not able to remove the waste products of our body and also the fluids. To balance that out, we need dialysis. So in the morning, I was woken up every day by 6:30 by our nurses. We have a meeting between the hospitals. Me and my partner cover all 3 ICUs with all these 4 gentlemen here. So in addition to the other intensivists in the area. So every morning between 6:30 and 7, I wake up and I review all the patients who are on the ICUs who need dialysis, whose numbers are the worst. We have to triage who needs the first treatment, who gets the next, and we go through each and every one. Then we coordinate with the ICU team and say, hey, what do you think? This is what I'm planning to do. This is how we are planning. And they also give their feedback, and we coordinate all through the day. This is like throughout the day, there is a constant 2-way communication between us, the nephrologists, or the kidney doctors, and the intensivists. So that's the second part of it. Third part of it is patients with kidney disease who are not on dialysis, who are the outpatients who develop COVID. That's another completely different ballgame, which we discussed outpatient during the previous conversation. The last one is the kidney patients who get hospitalized who are not on dialysis. So and the fifth category is patients who are on dialysis who gets to the hospital but not with COVID. So you're able to manage this. It's a jigsaw puzzle in the mornings.
Right.
So if you have a dialysis patient with a COVID, we cannot dialyze the same patient with the non-COVID patient. So we need to able to allocate the resources appropriately, and we will able to bring down one patient to the dialysis unit who's not on COVID, and we cannot do the same with the COVID. So we have to wait till the last shift and able to clean before and after. So it's a completely a different logistics. And difficulty, the most difficult part is not having enough dialysis staff in the West Texas area. And they do not grow in trees. They need to be trained. It's a big heart of the medicine. And unfortunately, if one staff gets COVID and they go on quarantine or isolation, we are stuck with few staffs. There are instances where my ICU nurses, the dialysis nurses, have worked 18 to 20 hours a couple of times, where one nurse, I remember, she went home at 3 in the morning. I had to wake her up at 6:30 because somebody was crashing in our COVID floor that she need to come back. So this has been a real surreal. And you wake up in the morning every day thinking you are having a good day, and you start off seeing that one or two are missing from the list of patients that you saw yesterday. That has never happened in my career of 15 years. So this has been the most challenging part. You wake up every morning and you see somebody is missing from your list, and you go back and see what happened, and middle of the night we lost them. So that's been a brief
Right.
yeah.
Well, Dr. Dar, what about you? How have you been affected by this as far as your daily routine?
I think just as everyone has touched upon, various changes similar to that. The biggest things have been some of them personal. I've never wore scrubs until this pandemic, as everyone can attest to that. I would do my rounds in the ICU, and in the afternoon I would come to my office and do clinic. So I had a particular attire. Now I've changed it completely. But apart from that, the basic things that I have noticed are the absence of family members at the bedside. To me, that's the biggest change that has occurred in my routine from prior to the pandemic. It used to be so easy. We would converse with family members at the bedside. They would visualize what was going on with their loved one, and we could make decisions after discussion. Now that is lacking. Now it's up to phone calls. And sometimes the volume is such that we can't make phone calls for everyone every day. And I think that creates a lot of mistrust and some anxiety amongst family members of patients. I think that's been the biggest change for me. I love talking to patients. I love talking to family members and communicating with them. And just the lack of it has been devastating to, it is to me, but I'm sure to a greater extent, you can multiply that by several fold of what the family members have to experience. They don't see their loved ones. They just rely on the information we provide or the nurses provide. And it's sometimes difficult to portray an accurate picture to them. I sometimes try when I'm on service at Odessa Regional Medical Center, I try to get patient families to come and visit their loved ones. And I think that helps a lot for their mental well-being, as well as decision-making regarding their loved ones' care. Apart from that, the daily routine is just the volume of patients, I think, that overwhelms us sometimes. The last time I was on service at Medical Center Hospital, we had about 34 patients on our service, and 28 of them were ventilated. And it just took all day, and you can't really provide the same level of care that you could with a smaller volume like we used to in our ICUs. It's just overwhelming. It's overwhelming for the staff. It's overwhelming for the residents who participate in the care. And then, of course, the PPEs. I'm in awe of the nurses who have to wear the PPE equipment throughout the day. We just wear it when we're on rounds, and then we retire to a separate area where we do our notes and relatively clean area. But they have to wear it all day, and I don't know how they do it, because underneath all of those layers you sweat so badly, and my admiration for them has gone up several fold because of that. Those are some of the things that have changed. Of course, the way we, in the beginning, just as Alex and Alexandra Alejandra have pointed out, we were ultra cautious. We would refrain from going home. We would, I would take off my scrubs, shower before I left the hospital. We don't do that anymore, but we were ultra cautious at the time, and we've just adapted as the pandemic has gone on. But it's very different from the good old days.
What about you, Dr. Catalasan?
Just to kind of give an example of what the good old days are, the way you rounded before, we actually want the family, involve the family in our rounds. They're always there. We communicate with them every day. They see us examine their loved ones there. They're actually part of the oftentimes multidisciplinary team. So their questions are answered in real time, right there. And that's what we've always encouraged. Like what my esteemed colleagues have said, the major changes are that's lost with this. They really can't go in anymore. Best they can do is FaceTime their loved ones, and even on patients are actually not on the vent. It's very hard to have the usual interaction, because often than not you're shouting to get yourself heard, all on these layers of masks and clothing and face shields and everything. So that took some getting used to, and it's still not usual kind of for us. I think the other thing that took us a while is most of us, when there's somebody that crashes or needs rescue or needs to be stabilized, we just all rush in the room automatically, like every day. We don't even think about it. With this one, with this COVID, you basically have to force yourself to mask up, protect yourself, and protect the entire team coming in. And I could tell you that that's still a struggle, because for people that work in the ICU, the people you work with, like nursing staff, the RTs, they're pretty selfless. They would walk in without basically anything if they see somebody crashing. So it's not uncommon for me to actually even now stop them, say, protect yourself first, and then rush and go in, and because if you get infected, nobody's gonna take care of them. And so that's always a struggle, because it's not automatic anymore that we can all go in and rush without protecting ourselves first. And that's markedly different from the way we kind of did things before. The third thing that I think for me that changes is just the way we round even after leaving, because our attires are different. Like I agree, I'm with Dr. Dar. I used to wear ties before. When we come in, now it's all scrubs. And when you go home, you have to think about the fact that you don't want to bring anything in. So the scrubs get left out. And then you have a protocol where you would go straight to the shower first. And that never happened before, to any of us. You tend to make sure that everything that you had in the hospital, you leave either in the hospital or you leave actually in the garage. It's the protocol that actually worked for us so far. Each of us have different ways, but the principle is don't let your clothes in the in the house as much as you can. And again, that's a marked change from the way we were doing things before. So to me, I think the most important thing that I've seen and I've experienced is just the routine selflessness of people that I work with. Is kind of amazing. And I think that's the difference between our community compared to other places. It's not uncommon for people to not think about themselves first. They would walk in the room and you basically have to stop and say, protect yourself first, because you don't have your full gear on.
Right.
It's not uncommon to see people help each other out if they have to turn a patient. It's called one of the things that we do is called prone ventilation to make your lungs get better, more oxygen. And prone ventilation is when you flip them, from the usual with your back, with your back, and then you lie face down. Basically, it's called prone ventilation. And so it's not uncommon for us to see 2, 3, 4, 5 people working as a team, working in unison to make sure that particular patient gets the best level of care. And so to me, these are just my observations. I'm sure my colleague can add to it, but that's kind of what I've seen so far.
Just wonderful. Thank you for that perspective.
I just want to add one thing to Catalasan. Dr. Catalasan, like you said, we lost one of the respiratory therapists, Dr. Dar, and we took care of it. He was working until he got sick.
Yeah.
So this happens to the staff who are working with the COVID patients. I'm sure Dr. Dar can add a few more words on that.
Yes, he was an excellent respiratory therapist, had served for about 30 years. And it was very difficult for other respiratory therapists, other staff. We knew him throughout these years, and it just hit home, his loss. We, of course, just like we do for everyone, we did everything we could. But unfortunately, the disease is so unpredictable. Some people get better, some people don't. It was quite devastating for a lot of people.
Of course, that's a good point. And kind of following up to that, we have somebody joining us this evening who suffered COVID from doing their job. Dr. Garcia, what was that like?
It was hard. I think, we see so many things on a daily basis that it's hard for your mind not to go to very dark places very quickly.
Right.
I was fortunate enough to be able to spend my self-isolation and quarantine at home, which my patients do not get to do that.
Mm-hmm.
But I have an 18-month-old, and my parents were staying with me. And so it was a lot of thinking about, if I brought it home, did my kid get it? Did my parents get it? In theory, I should be in a lower risk stratification based on my age, etc. But what about my parents who are older than 65? What about my kid who is still very young? And so it was hard. It was hard at the beginning. I felt a huge relief once the 14 days were done and I was able to get out of the room. I isolated. I was fortunate enough that I had a place to isolate myself from the rest of the family and that no one else in my household was affected by it. But it's hard. And the problem is, we're all exposed on a daily basis. This is the job we sign on for. And I do understand that. And even in spite of doing everything the way you're supposed to do, the fact is, I've been doing this for 8 months and I just felt at some point we were going to get here and there we are.
You did.
Yeah.
Do you remember when you first started coming down with the symptoms? Can you kind of walk us back to that? What was your initial symptoms? Kind of, and what was the first reaction you had when it was like, oh gosh?
Yeah, so, lately when I've been working in the unit, you spend so much time with taking care directly of patients. A lot of times with the protective equipment, you don't drink as much fluids as you would on normal basis. Your eating habits are a disaster most of the time. And so headaches are not uncommon, especially towards the end of the day. So I didn't pay too much attention. But then that particular day, the headache was different. It was a frontal headache, kind of a sinus when you have sinus infection. When I moved my head to the sides, the headache got really, really worse. which was very atypical. I don't suffer from sinus infections. So I was leaving the hospital when the headache started. And since I know I'm a population at risk, I had already bought a pulse oximeter to measure my oxygen levels, and I had my thermometer and stuff. So as soon as I got home, I measured my temperature and I had fever. So at that point, it was already late in the evening. I figured, more than likely this is gonna end up being COVID. So just gonna wait until tomorrow and then go get tested. That was on a Sunday evening. I got tested on Monday. I was told that day the results wouldn't be back for 5 days for PCR testing. So then I found a place that did quick testing, the antigen testing. But at that point, I had already had fever for 2 days on a road, and I was taking Tylenol every 6 hours just to get the fever under control. So I got my rapid testing done and came back positive on day 3 of symptoms starting. And then in my case, it was bad compared to other young persons because I had fever continuously for 9 days on a road. So I was dependent on Tylenol to keep the fever under control. The headache went away on day 4. And after the headache went away, then the dry cough started. And it started pretty bad. And then I still have here and there a little bit of cough, but I think by the end of the 14 days, the cough was better as well. And overall, because of the fever, I just felt really, really exhausted all the time. I'm relatively young. I have no medical problems, and I kept checking my oxygen levels and my heart rate. And something that I tell people, my heart rate, normal heart rate, is usually between 60s to 80s. My resting heart rate laying on the bed was 120 for the first 7 days or 8 days of symptoms. So my heart was in stress, evidently, and I just felt really, really bad. Thankfully, like I said, after the end of the 9 days of fever, I started feeling closer to myself. But even now, back at work, I've been back at work for 2 weeks now. We had a patient that needed immediate attention on the 8th floor, and I decided, like I would on normal basis, to take the stairs from the 2nd floor. And I got to the 6th floor and I had to stop because I couldn't catch my breath. And by the time I arrived to the patient's room, the respiratory therapist kept looking at me like, I think you might be the one needing the oxygen at this point. So it's still taking a toll on you. Your body's still trying to recover from it. But like I said, thankfully, I feel much better now. And thankfully, I'm able to be back to what I love to do and take care of my patients.
Amazing story. Dr. Reddy, I think you wanted to ask some questions of Dr. Dar as far as kind of what this thing looks like in patients that go from kind of an outpatient to a more critical care setting.
Yeah, so Dr. Dar, the question is, we hear this a lot of times. I'm trying to be the devil's advocate here. Can you go through the why some patients recover so easily and some of them end up requiring your services?
Difficult to tell. Who's going to do what? I know there are risk groups, obesity, diabetes, presence of heart disease, kidney disease. Those are conditions that predispose patients to the illness. But I found, and I don't know what the others, if they share the same experience, but it's very unpredictable who's going to progress to what. It doesn't matter what treatment you've had before, what treatment medication-wise we offer in the hospital. I mean, in the beginning, we used a lot of convalescent plasma. We used, we still do use remdesivir and now IV Decadron, dexamethasone. But despite all of these measures, there's some patients who progress and others who don't. Some recover quickly, some progress and become admitted to the ICU and eventually end up on a ventilator. And these are unpredictable things. I don't think I've been able to identify which patient is going to follow which route. I don't know what the others' experiences are. Alex, Alejandra,
Yeah. So, you know, like,
Gerardo.
as you said, is very unpredictable, and we're still learning. I mean, we know, as you mentioned, there's some risk factors that we know predisposes patients to have, you know, worse outcomes or higher risk of become critical and go into mechanical ventilation. As you mentioned, like we've seen, like very often, like obesity, I think is a big important risk factor to have worse outcomes. And then between the others, diabetes, hypertension, as you mentioned. But you know, I just from my experience, you know, it's still surprising me this disease because, you know, I remember some, like, you know, few patients that, you know, no major risk factors, they're not obese, not that old. And those, you know, you thought like this patient will do fine. You know, I think I will be able to get it through the ICU without getting intubated, and they start doing fine and they do okay for a few days. And, you know, you feel excited that, you know, you're making some progress, and then or the progress they just plateau or they start crashing on you, and it's completely unpredictable, and it's very, sometimes it's just frustrating because, you know, when you think that you're making some progress or patient is doing, you know, what supposed to do, and you tell them what to do and they will do it fine, and then they got worse and they got intubated and they become critical, and it just becomes like a cycle. Like there's a lot of up and downs in the progress, and that has been frustrating, you know, for me. It's just unpredictable.
Mm. What about because we've gotten some questions about this as far as people that who've recovered from it. We had one viewer just asked a question a while back. Okay, you know, addressing the issue of family members not being able to go in. What if you're somebody who's gotten the virus and recovered from it, so you have some type of immunity to it? Why couldn't you be allowed to go in to visit that person, that family member in the hospital? That's one question. The other question is with the vaccine coming out, and it goes to the recovered patients. If you've recovered within 3 months and you still have some kind of resistance there, should you get the vaccine, or should you rely on your kind of your immunity to it? If y'all could take up one or both of those questions.
I'll take the vaccine one since I already got COVID. I'll
There you
just
go.
have my personal opinion there. You know, to me, it's truly just common sense. You know, you're offered an extra layer of protection. Someone is telling you, you know, you can have 2 or 3 layers of protection. Same rationale for using a mask. Are all of them 100% bulletproof? No, the answer is no. So if you have the chances of having 3 different layers of protection, why not take it? So I got COVID. I haven't been tested for antibodies, but I'm hoping that I would have antibodies. And I'm still planning on getting the vaccine when it's available, because again, it's an extra layer of protection. And who doesn't want that extra layer of protection?
For me, for the second question about the immunity and why aren't patients being allowed in, again, there's no guarantee that even if you got it, that you won't get it again. We don't really know if the antibodies that you develop after disease is fully protective, because there's reports that people can get it and can get it twice. So that's one. And then the second thing is the second event is you could potentially still be infected even though you had it before, and it's still spread it around all over your family or your loved one. And so that's the reason why both hospitals, or all three hospitals, actually initiated policies where there's no exceptions in terms of, you know, I've had a positive test, I recovered, can I go in? I think the risk is that we don't know whether your risk actually goes down to a level that is negligible to spread it at that point.
Yeah, we've got some more questions saying if I've got COVID, if I had COVID and I recovered, can I be around other family members that have it and still be safe? I guess the question is, it depends, right?
I would say my practical I guess question would be still protect yourself, like what Dr. Alejandra was saying. I think 1, 2, 3, 1 layer of protection is good, 2 is good, 2 is better, 3 is the best. So if it was me and I got COVID, I would wear a face mask. I would make sure I'm socially distanced, and I would make sure I would stay away from people that potentially will not do well if they get COVID. So 3 layers of protection is better than 1 or 2 or 3, in my opinion.
So talk about, each of you kind of talked about the frustration of not being able to communicate with the family, having the family there, and the frustration of having to suit up with all the PPE. Talk about other frustrations that y'all deal with, whether it's people that have misconceptions about ventilation, people that have misconceptions about different therapies, or what your role in an ICU unit is. Tell us more about some of those frustrations.
Well, I mean, I think, for me, some of the frustrations is like there's a lot of misinformation out there. I mean, if you go to the internet, there's a lot of misinformation out there. And some of the particular things I've noticed, like, from patients or families is that, for example, that, patients, they die because of the mechanical ventilation. Okay. And that's one of the misconceptions. It's not because of the mechanical ventilation, it's because of the like the disease process that led to the mechanical ventilation. That's when sometimes, it's hard for families to understand. It's not like, sometimes it's just the last resort that we have to put a patient on mechanical ventilation. And we try to do our best, like even when they get into mechanical ventilation, to follow all the recommended guidelines that we use on mechanical ventilation, like to protect the lungs from further damage. But at that point, the disease process is so advanced, so severe, that patients are still dying, and not just because of the mechanical ventilation, it's because the disease process that led to the COVID. Okay. And just one more thing, like the other, like a particular like frustration I found is like, in terms of misinformation out there, when you go into social media and everything, is like they still thinking like, patient, they didn't die because of the COVID. They died because of all the associated conditions. But let me tell you that, if the COVID made those associated conditions, got worse to the point that the patient got sick. Otherwise, without the COVID, a lot of those patients, they were still out there with all the associated conditions. That, that's another misunderstanding that people has, that, sometimes we're still dealing, with this situation.
You'd be telling me, Pat Canty, you just need to continue to lose weight and take your high blood pressure medicine. if it weren't for COVID, that's how much of the difference it is, I guess, what you're saying.
Exactly. I don't know. That's some of the few frustrations I found, like, every day. I don't want to but I just let others to talk about the frustrations as well.
Dr. Catalasan, what have your experiences been as far as misconceptions? I know there's some people, they hear that oh my gosh, they're going to put Bill on a ventilator, and they automatically assume that that's a death sentence. That's not good. What can you kind of speak to that kind of misconception out there as well, or?
Yeah, I think the misconception is the ventilator is the cause of death. Actually, the ventilator is the one that will save you from dying at that particular moment, is one that we would all like to emphasize. If we don't put you on the ventilator when your ICU doctor or lung doctor, or probably any doctor that's qualified to judge it, like ICU hospitalist, deem it's necessary, you probably won't survive the night, or probably even the next couple of hours, if it's that day, just based on all our experiences with COVID. And so to us, a ventilator is a tool. It's something that we place on somebody until the lung recovers enough, and until the medicine that we give the patient kicks in. I've had occasions where I have to explain to a patient refusing the ventilator because I didn't think they had truly informed consent when they said no, and that takes a while. And you become a little bit nervous, because when as to how my colleagues can attest to, when a COVID patients talk, their saturation, their oxygen levels tends to go down to really dangerous levels. And so you're speaking to your patient and you're looking at the oxygen levels, and you're wondering, this patient hopefully will not pass out before the end of the conversation. It's that bad sometimes. But if I'm going to pick one, it's to say to our community, I think, when a qualified ICU lung MD, a nephrologist tells you that it's time to be on a machine, that's basically a life-saving recommendation at that point in time. And again, it's not the ventilator that's going to cause harm. It's the fact that your COVID pneumonia or a disease process has advanced far enough that you can no longer breathe on your own, that you need help from a machine. Otherwise, you're going to either, one, stop breathing, or second, your heart will stop along with it, or most likely both. It's called the cardiopulmonary arrest, actually.
Right. Real quick, I know Dr. Bastidas, you need to jump off the call, but I wanted to thank you so much for taking the time to be with us this evening and help us talk about some of these topics. And thank you so much, and stay well. We talk soon.
Well, thank you so much for give us this opportunity to share with the community some of our just personal experience, and I think this is a great opportunity for community to see our faces, what is behind the mask,
right?
And just to share a little with the community a little more about what is our day to day. And before I leave, I want to just emphasize one thing. I mean, we're still learning about this virus. It's still not real proven therapy that will make a big difference for those patients. I can tell you there's no like a magic bullet for this, okay? And I think that the best thing we can do to this is just prevention. So basically use the face mask, keep social distance, wash your hands. Probably is the best intervention. Just avoid to have this, because when patients they get real sick or they get critical, I can tell you there's no magic bullet for this.
Right.
Okay.
Thank you so much.
Thank you so much.
Thank you. See you soon, and stay well.
Thank you.
Thank you. So talking about prevention, and I'd like to go back to you, Dr. Catalasan, because we were visiting earlier about this. You're talking about there's the other frustrating thing about people not wanting to wear masks because they seem to think that there's a loss of freedom there, but there's also a very stark loss of freedom when you're on a ventilator. And you have to do that day in and day out. Tell us what that's like, and kind of what do you think about that when you hear people say, I don't want to wear a mask?
Yeah, absolutely. I think that's why there's kind of a disconnect between people that disagree with masking and the side effects of it, if you happen to be the unlucky one among the few that gets it. I mean, the way we would do it is, if you have COVID and you start failing usual therapy, which in this case is a high flow oxygen, that goes through your nose, the next step usually is we'll put you on a mask. It's called the non-invasive ventilation. But the ultimate one is called mechanical ventilation, where we will put a tube down your throat, and apologies for being graphic, but probably this long, and then put it in your throat, right in your airway, at the same time while paralyzing, giving you sedation, and then you get hooked up to a machine, all the while getting sedatives and pain medications enough to cause, kind of an induced coma, so you don't feel anything or you don't hurt at all during that time. And so that, to me, is the ultimate loss of freedom. You won't have a choice in the matter, because if we don't do it that way, you probably won't survive the night. Is one. The second thing that happens oftentimes is in people that are severe enough, we tend to do what's known as a prone ventilation. If the usual conventional machine settings fail, we tend to put them on lay them towards their stomach. And it's called prone ventilation, where we're trying to get as many good lung units as much as possible, that we tend to flip you, on your abdomen. And oftentimes when we do that, we actually paralyze patients, which to me, in my opinion, is the ultimate loss of autonomy. So to me, it's risk-benefit ratio is markedly different for us, because we deal with these disease day in, day out, and we know what ultimate loss of autonomy and loss of ultimate freedom is. It's on a patient that we take care of day in, day out, sedated, paralyzed, intubated on hooked up to a machine, that's semi-awake, that can't even see their family members. And to me, that's kind of heartbreaking. Like what Dr. Dar shared with his experiences, one of the frustrations is that we can't answer questions from family members in real time anymore. Because the 30 minutes of time that we spend with family members, that is oftentimes to answer all those questions, are 30 minutes of times are oftentimes that we can't ill afford anymore because there's somebody else crashing upstairs that we need to stabilize. And it's gotten to those levels, on certain days that you really have to pick when and where, you could afford those meetings at some point. And so to me, what I would recommend to the committee is the benefits far outweighs the risk of just practicing good preventive pandemic measures. Mask up. If you wear a mask, it's good. If everybody else wears a mask, it's better. If we stay away 6 feet from each other, it's probably for the best. And so to me, I just want to make sure that, I didn't mean to be graphic, but I just want to make sure that when we say total loss of freedom, I think somebody sedated, paralyzed, semi-awake, semi-conscious, semi-comatose, paralyzed, and on your stomach just to get some lung units working. To me, that's the ultimate loss of freedom. I just want to make sure that when you're refusing to wear a mask, that you're aware that that's a possibility that can happen to you more likely than not if you end up catching this, this and end up in the ICU.
So I see, Dr. Catalasan, the people who are not socially responsible, they carry the virus to their families. This is the most important thing. We see this, our dialysis patients, which are vulnerable patients. I'm losing so many of them. Some of them never left the home. The only thing they have done is they met their grandkid who came to visit them for a social visit. He may not be thinking that he's going to get sick. He doesn't understand the implication of not masking. He may get better, but that one simple visit to his grandparents can prove vital. So I lost a patient recently who had a grandkid visiting him just for a couple of hours, not even like a big thing or anything. He came to check on their well-being and everything. And he got COVID 2 days later. By then, the grandmother got it, and we lost her recently. So those are the simple mistakes that they can happen. It's not just you; you are carrying to the most vulnerable people of the society.
Yeah.
So it's a social responsibility for all of us to keep us safe from carrying the COVID.
So help us understand kind of how the hospital is, I don't know, divided up. So, I mean, obviously, if I have it and I have to be hospitalized, it's not like I go automatically to ICU. Maybe I do, maybe I don't. But tell us the different levels at which a hospital would handle a COVID patient, okay? And to what extent each of you would be involved in any or all of those levels.
Go ahead, Dr. Dar.
Oh, okay. No, go ahead.
So usually when the patient comes through the ER, that'd be the entry door for the hospital. They'll get a first assessment. And depending on the severity of the disease and how much, medical care they need at that point in time, a decision it's made or where in the hospital they need to go. So let's say patient comes to the ED and they're sick with COVID, they have some mild symptoms, but they do need oxygen. That's kind of the first step on when you say, well, these patients should not be safe to go home because these patients need oxygen, we need to admit to the hospital. And so a patient will go to what we call a COVID floor or regular medical floor that it's designed for COVID positive patients. And unfortunately, at the beginning of the pandemic, we were seeing so many patients, then it kind of slowed down. So you had enough capacity in the ICU. So if the patient needed more oxygen that what the nurses on the floors could manage, usually it's around 50%, then those patients would go to the ICU. The second wave of the pandemic has hit us so hard that unfortunately we don't have enough ICU beds. We open in Medical Center Hospital 2 extra wings to be able to accommodate critical EO patients in the hospital because our beds were not enough. And so that has made us kind of stretch our resources in a way that a lot of patients that need even more than 50% oxygen will stay on the floors, and then we'll just keep an eye on them and make sure that they're getting what they need. Once the patient is in distress, respiratory distress, or their oxygen levels cannot be met on the floors, they're needing too much oxygen to safely breathe, then that's the time they come to us in the ICU. And a lot of times we'll get calls from patients that are on the floor because they're getting worse and they want one of us to assess to see if the patient needs to be moved to the ICU. Once the oxygen requirements are high, the patient comes to the ICU. And, you know, Alex mentioned before, and Dr. Catalasan mentioned before, initially they'll need the high flow cannula that can give up to 95% oxygen. When that's not enough, they'll go on non-invasive, which is a mask that can give up to 100% oxygen with pressure. And when all of that fails, then the next step is invasive mechanical ventilation, which is the tube and connect to a ventilator.
Just to make a point here for the community, what we breathe is 21% oxygen in the atmosphere. So they're talking about 100% is the maximum oxygen that can be delivered in the ventilations. Dr. Catalasan, what about in MMH, Midland Memorial?
Yeah, I think all RMC, MMH, and MCH, all our experiences are kind of the same. Right now, we have to open up a wing, a flex care wing, a universal care wing in the 9th floor. The 9th floor is shelled out. They can potentially handle that. And as of a week ago, we actually had to take over 5 ER beds and convert it into an ICU bed, just because we didn't really have any more space where we could put patients from safely. Again, they have to, we have to expand our capacity to both care for not just COVID. We also have to think about the usual non-COVID ICU patients coming in, trauma, accidents, heart attacks, because those doesn't stop and those doesn't go away just because we have COVID. And so we, at this point in time, we're actually flexing at least 5 beds more in the ER for non-COVID patients.
At ORMC, we little different in the sense that we take care of all the COVID patients, whether they're on the floors or in the ICU. So there's a little advantage to that in that we can actually make the decision of when to move a patient from one level of care to another. But they come to the ER, and first of all, the decision is made that they need to be admitted. And a little difference from the beginning of the pandemic. In the beginning, we would admit most patients who required a small amount of oxygen. Now, from the ER, we try to send as many patients home as possible, just because of shortage of beds. We provide them with oxygen. We give them a pulse oximeter prescription and advise them to follow up with their primary care or return to the ER if their numbers fall below a certain level. But once they're admitted, again, everything follows the same pattern: high flow oxygen to CPAP or BiPAP, non-invasive positive pressure ventilation through a mask. And then if that fails, then intubation and mechanical ventilation. I say we just have a little difference in that we have control over all those phases, admission from the ER to the floor, from the floor to the ICU. We take care of all the patients. And to me, that's a bit of an advantage here at ORMC. It's impossible to do at medical center just because of the sheer volume of patients that you have to manage. And I'm sure at Midland Memorial too.
Yeah.
Dr. Dar, I'd love to get your perspective, kind of if you could share some of your thoughts on kind of, what people need to do around right around now with this virus. We've all talked about wearing masks and things, but share with us some of your thoughts on things to do, but also maybe things to keep in mind about, positive attitude or whatever with all of this. If you
I
could
think
share
so. I
some of your
think,
thoughts.
just so happens a couple of days ago, I was talking to one of my neighbors, and his perspective was that we need more physicians to come out, people who are actually treating patients to come out and talk about the illness. And maybe he thought that would be, that would make for a more convincing argument than community leaders or politicians telling them to do the same thing. And I agree. If we, I'm sorry, I'm not trying to be political or anything, but if we had adhered to face masks and social distancing, maybe we wouldn't be in the position we're in right now. We could have opened up businesses. We could have done that in a much more sensible and cautious way. But it could have been done. It's just that when the mask mandates were taken away, everybody thought it meant freedom from masks altogether and no social distancing. But the fact is that those measures do help. There was a time when we had barely 2 or 3 patients in our COVID unit here at ORMC. And then there have been times when at its peak, we've even talked about getting the ethics committees involved to make decisions about potentially having situations where we have to decide, which patient to assign a ventilator or not assign a ventilator because of shortages. So all of that has occurred at a time when, face masks and social distancing was thought to be, hindering on civil liberties. But I think that people are not stupid. I think if we explain things properly to them why we're doing these things, I think they would adopt those measures a lot better and more universally than they do, when it's enforced. I think education is the key, and I think it's our jobs, and I think this forum is one of the places where we can educate our patients and the community in general about why it's necessary. And those are my thoughts.
Here's an interesting question, and it's posed to you, Dr. Dar, but I'll throw it out to not just you, but everyone. This one viewer says, what have you learned from the first patient that died of COVID to the most current one? What have the doctors learned since then to now?
Oh, different types of management. I don't think people pay a lot of attention to medications. I don't think medications have made any difference to outcomes. I think the way we've managed patients in the ICU has changed a little. It's changed in the sense that in the beginning we would jump to place patients on ventilators based on experiences of physicians up in New York, at the height of the pandemic. There were all sorts of protocols which suggested that maybe, if you were requiring 6 liters of oxygen through a nasal cannula, perhaps you needed to be on a ventilator, maybe non-invasive ventilation where you place a mask which delivers oxygen under pressure. Maybe that was hazardous and liberated, aerosolized the virus and posed risk to everyone around. And no high flow nasal cannulas. And so those things have changed. We do try all of those things before we get to the point of placing patients on a mechanical ventilator. One thing I would say is that from the first patient to the last patient, the first patient who we placed on a mechanical ventilator and didn't survive to patients right now, it's the same frustrations that we've had from day one to now. And a lot of people think that, we become immune to all these things, all the suffering, but we're not. When I go home, I think about my patients. I think, what could it be that I could have done better today? What can I do better tomorrow? We go home with, we've had young patients on ventilators, and, we just pray that when we go in the morning, we find that their oxygen needs have dramatically decreased. I mean, those are wishes, and those things haven't changed. It's just as stressful as it was on day one to now.
Who else? Dr. Garcia?
Basically, I think the main thing in terms of medical, it's what Dr. Dar just explained. I think we were more aggressive at the beginning, and I think the aggressiveness of putting people on the breathing machine was, a lot of it was triggered by fear of not knowing how this virus behaved. And we've learned with time that we treat these patients like any other patient with respiratory failure would. And so we have, an escalation of care like the one we mentioned before. I think throughout the entire time from patient number one up until today, I think I would agree that I think we all realize that we have control of very little, that we can proportionate a good environment to allow the body to heal if the body is going to be able to heal. I don't think we've learned that there's any magic medications that we can use, that it's a very slow process, that you don't see changes quickly, that once the patients get on the breathing machine, it takes a long time. I think that's it.
How did it change you? The fact that you actually contracted it and dealt with it and recovered from it. How did it change Dr. Alejandra Garcia before getting that until coming through it and recovering from it?
I have to say I understand their fear better. I look at that patient who has been on 100% for several days, and that it's not getting better and it's slowly getting worse. And the day that finally that patient is no longer able to keep up with their breathing, and I've been talking to that same patient for the last 6 days, and like Alex was saying earlier, they did everything that they were supposed to. They follow every single instruction. They were the perfect patient. Their lungs just did not recover. And the moment of talking about, it's time, you're no longer able to breathe on your own, and I need to put you on the machine to try and help you breathe and see if we can get you through this. And I see the fear in their eyes, and I understand that fear better.
Mhm.
I share that fear with them.
Dr. Reddy, Dr. Catalasan, any thoughts to that?
Speaking from our colleagues, the fear is always there, but I can almost assure you, like most, if not all of the people that works in healthcare, the fear more is giving it to somebody that you care about when you go home. And I'm sure Dr. Garcia can attest to that. It's one of those things where, we all kind of sign up for this, but your loved ones didn't. They certainly didn't. They don't do what you do. They don't know what you know. They're not supposed to be exposed to things that you're exposed about. But I could tell you, all of the RTs, RNs, nursing staff that we all have worked with, they show up for work every day. There's no attrition rate at all in any of our hospitals. Like they're still there for the community, and they're still there day in and day out, even at the peak where there came a point where we, like what Dr. Dar was saying, that we're talking about repurposing anesthesia machines just so we could save as much people as we can, because we're running out of ventilators, at that point in time. Right? And I'm always amazed by people that we all work with, because they are asked to do the impossible basically almost every day, and they figure out a reason to do it every single day.
So I want to add to what Dr. Catalasan said. When this pandemic started, we started looking at the pictures like anyone else from Italy, France. We had that New York, and the ability of our community to stand up over the last 3 months. It's just incredible how the staff has stood up, how the intensivists, everyone put their hands up and said, I'm available. Yeah, almost every healthcare provider in this area, I can guarantee, has done extra shifts in the last 6 months. I can't remember anyone who said, okay, I'm not available this month or this week. Every specialty, the RTs have done extra, my dialysis staff, oh my God. They had to go overboard with the available resources. The nurses, ICU nurses, and that is incredible to see how much our community can sustain in this kind of a pandemic compared to the size of a big cities like New York or El Paso. We have done reasonably well in spite of the spike in pandemic. And to add to what the question was, what did we learn in the 7 months? The one thing about this pandemic, I've never been in the other pandemic, so I do not know. For this one, at least the information flow is so seamless across the world and across our community, physician community. And the ability to, the people I work with is so easy to pick up a phone and ask, hey, that's the biggest advantage in West Texas that we have. We know each other so well. We pick up our cell phones and we discuss about the patients right away. There is nothing like you call an operator, wait for somebody to page you, and takes you another 10 minutes to come back. It's so seamless. We discuss, and the information is. I remember discussing with Dr. Dar multiple times. He calls up and says, "Hey, I saw this article on this. Can we try this on this patient?" We have done that when we reviewed the literature from across the states. And I remember with Dr. C, we tried some treatments on a patient who was only 25. So we had to try all the best resources. So we reviewed the literature and we said, can we do it in West Texas? We said, absolutely, why not? We tried that. So that seamless information, the way we communicated that, and the staff is a big change. Not necessarily the outcomes, but the cohesiveness of our staff and the hospital systems. It's an encouraging sign. All three hospitals work as a team now, which is amazing to see how easy the information flows and the patient care. Don't you guys agree?
Completely agree.
Yes, absolutely.
Yeah, I mean, I've even noticed that just from my perspective. It's no secret that there's been healthy competition between the three hospitals for years. And the interesting thing about this pandemic has been when certain kind of governmental entities don't tend to get along or not necessarily aligned. It's been the hospitals that have all stepped up and have aligned themselves and really done an incredible job and communicating with the public too. It's been incredible to watch. And I think at this point we've got to where we're probably going to have to wrap this up. We've gone over, which is a good thing because there were plenty of questions, and I can't thank y'all enough for devoting the time to come here tonight and tell your stories. I mean, the information has not only been so useful, but it's been very compelling. You're wonderful human beings as well as incredibly talented physicians, and you've each been able to put that human face on the effect a pandemic has on the community and the people that do the best they can to help that community heal. And so I can't thank you enough. And Dr. Garcia, I'm glad you're healed up and back, and that's wonderful. And I hope the rest of you stay well. To our audience, I want to thank you for joining us tonight, and once again to Ravi Shakamuri and Star Hospice for making this possible. And on that note, please mark your calendars. Next Tuesday, we will be hosting an all Spanish discussion on the Star Hospice Facebook page, so we can help kind of get our physicians to help get out that message to our Spanish speaking community too, so they can kind of be better educated like all the rest of us, and as we try to do the best we can to navigate this pandemic and stay well. So look forward to that. I think it's going to be another great presentation. And Ravi, I'm going to turn it over to you.
Pat, thank you. Thank you for being an exemplary moderator, for connecting our people to our physicians. And Dr. Catalasan, Dr. Garcia, Dr. Reddy, and Dr. Dar, thank you very much for your time. And we have been having an amazing feedback from the community, and they're extremely appreciative, grateful, and thankful for everything what you guys do, professionally what you do, and personally the risk you take to make this happen. So I think everybody's blessings are there, and we thank you for making time to talk to the community, and wish you the best and safe navigation through all these difficult times. Thank you all. Thank you very much.
Thank you very much.
Thank you.
What a privilege.
Take care.
Thank you.